Hi, everyone. I think we're going to go ahead and get started. If you're just joining us, we'd love to see your name and organization info in the chat. And if you're working on an integrated health program yourself, particularly in evaluation, we'd love to see that info too. I'm Tori Taylor, the Associate Director for D4I. I'm going to introduce our presenters today. This month's webinar, led by UNC's Sean Curtis and Jessica Farringer, will explore an evaluation of integrated health programming in Nigeria. Just a quick overview about D4I if you're not already familiar with the project. We work to support countries in data generation and use for programming and policy, including through strengthening individual and organizational capacity development. We also help ensure integration of cross-cutting areas, including gender in monitoring and evaluation. Today's webinar is actually the fifth and last one in our series on integration. Some of you probably joined us in May for the most recent webinar, which featured integration of zoonotic and human health data in the One Health system in Burkina Faso. All the recordings and slides from these webinars are posted under the resources tab on our project website. The next series is actually going to be on health equity, so be on the lookout for more information as that series gets underway. Next, I'd like to introduce our presenters. Just a few notes first. Please try to hold your questions till the end. We do have designated time for Q&A after the presentation. Jessica Farringer is going to be facilitating Q&A, as I'm going to have to drop off the call a little bit early. Apologies for that. Our first presenter is Sean Curtis, PhD. Dr. Curtis is a professor in the Department of Maternal and Child Health at the Gilling School of Global Public Health at the University of North Carolina in Chapel Hill. She's also the faculty principal investigator for D4I. Her work focuses on monitoring and evaluation of population health and food security programs, and on reproductive health in lower and middle income country settings. Our second presenter is Dr. Jessica Farringer, PhD, who is the D4I director and a social and behavioral scientist. Her research focuses on mixed methods evaluation of population and health programs in lower and middle income countries. She also has expertise integrating gender into monitoring and evaluation for global health programs. And with that, I'll turn it over to Sean. Thank you.
Great, thank you, Tori. Can everyone see our slide presentation? Okay, Tori?
Yes.
Excellent, thank you. Great. Well, welcome everyone. Today we are using the Data for Impact Nigeria Health, Population, and Nutrition Multi-Activity Evaluation as an example of an evaluation of an integrated health approach. The webinar objectives are threefold. First, to describe issues that arise when when designing the evaluation of an integrated health project. Second, to illustrate how those issues were addressed in an evaluation of an integrated health approach in Nigeria. And then lastly, to identify lessons learned from implementing the evaluation of the integrated project in Nigeria. Before we get into the presentation, we just want to acknowledge that this work is it's based on work from a large team. We have a number of us with Data for Impact, as well as our local research partner, Data Research and Mapping Consult, or DRMC, who have contributed to the work that we are describing today. And with that, I will turn the presentation over to Sean.
Thanks, Jessica. So Data for Impact was asked to conduct an outcome evaluation of 4 USAID Nigeria health, population, and nutrition activities, with a focus on comparing the strengths and challenges of an integrated health program approach with a disease-focused approach, in this case, focusing on malaria. The 4 activities are listed here, along with their start and end dates, which you can see differ across the 4 activities. Next slide. So what do we mean by an integrated approach and a disease-focused approach in the context of this evaluation? So an integrated model implements a coordinated set of reproductive, maternal, newborn, child, and nutrition and malaria interventions, as well as health system strengthening interventions. And this is the model implemented by the Integrated Health Project, or IHP. A disease-focused model addresses one health area only, and in this case, the focus is on malaria as implemented by PMI for states, or PMIS. In the malaria model, there are health systems and strengthening interventions in the context of malaria programming, and so these could potentially have impacts beyond malaria programming. Both models also include demand creation activities implemented by Breakthrough Action Nigeria and commodity procurement and distribution interventions implemented by PSM. In the integrated states, those activities focus on the broad range of reproductive, maternal, newborn, child, nutrition, and malaria interventions. In the malaria-focused states, they focus primarily on malaria. Next slide. So the development hypothesis that this evaluation addresses is that shifting to an integrated health programming approach from a disease-focused approach will lead to broader and more sustainable improvements in health system and health behavior outcomes. So this list of questions illustrates the types of questions that are particularly relevant to integrated health programs. These reflect questions that came up when we talked to stakeholders as we designed the evaluation. For example, if an activity covers multiple health areas, will they see results for all health areas, or will some areas see more results? Or does adding an integrated approach accelerate progress towards sustainability? Or does it lead to more resource substitution, leading to slower progress towards sustainability in the long run? Next slide. So these evaluation questions raise a number of issues that need to be considered in the evaluation design. First, there are multiple outcome domains. So malaria is the primary outcome domain for PMI for states, but integrated health programs aim to influence many more health areas. Sustainability is also a relevant outcome domain in the development hypothesis, and there could be trade-offs between these different domains. There are also specific questions around process in integrated health programming related to the feasibility of implementing a wide range of interventions in practice. Integrated programming magnifies the complexity of the theory of change, as there are multiple potentially intersecting mechanisms of action that also likely interact with context. There were also other factors to consider that were not specific to integration. In particular, the evaluation is a portfolio evaluation with multiple activities working in different states on different timelines. And as in all evaluation designs, we have to balance technical considerations with cost and feasibility considerations. So let's talk a little bit about the design and how we address some of these issues. So there were a number of core design principles that we considered when we started designing the evaluation that was agreed in collaboration with USAID Nigeria and other stakeholders. The first is rapid feedback, the idea that results will be shared regularly and quickly with USAID and implementing partners. Second, the evaluation should be holistic and at the portfolio level. So focus is on the synergy among the 4 activities and how they achieve shared outcomes, not on evaluating any individual activity. The evaluation should be participatory, so maximize stakeholder engagement and talk through action planning based on evaluation findings. And then we are aiming for an adaptive design that is flexible, allowing new questions to emerge and the potential for evolution of methods and tools as needed. We're also going to use existing data as much as possible to improve efficiency and maximize the use of what's already there. So, turning now to our first design decision, we chose to use a comparative state case study approach. So the 3 states that we're working in are shown here. Zamfara and Kebbi in the northwest reflect similar cultural contexts but with different programming approaches. KEBI has the integrated approach implemented by IHP, while Zamfara has the malaria-focused approach implemented by PMI for states. This is the main comparison for comparing integrated versus malaria-focused approaches. Ebonyi is added to bring in more context. It is in the Southeast, so a different cultural context, and has both approaches operating at the same time. So statistical impact evaluation is not feasible or appropriate for this evaluation. That works best for relatively short causal chains and narrow evaluation questions. The pathways and questions in this evaluation are complex, so we need to use a complexity-aware approach. We used a theory-based approach to help us put the pieces of the evaluation together. This theory of change was developed with stakeholders and is high level. It is not meant to be comprehensive. Each box in the theory of change could be unpacked further with a theory of change behind each one of them, but that would be too much detail to be manageable here. So here we focus on laying out the primary components of the activities and how they are expected to work together to help us define measurement domains and to organize the evaluation. We kept it linear, even though we might expect more complexity in the theory of change, because that is more familiar to most people and lays out the expected pathways to change relatively simply. So here we show the different outcome domains we decided to address. We hypothesized that integrated and disease-focused approaches might have different effects in these different domains. Within the health behavior and service delivery domains, we look at malaria outcomes and also at antenatal care and family planning outcomes. Malaria outcomes are the focus of PMI for states, but are also part of the integrated approach implemented by IHP. We are interested to see if the changes in malaria outcomes are similar under the two approaches or not. The integrated approach is expected to address other outcomes too, however. ANC and family planning are used as comparison services. The PMI for states programming might also affect ANC outcomes through their work on malaria and pregnancy, but integrated program addresses ANC more broadly. We do not necessarily expect to see changes in family planning under the PMI for states model because family planning is not something they work on, but we would expect that to change under the integrated IHP model. What we are trying to explore with this approach is whether we see broader outcomes under the IHP model, but deeper ones in malaria under the PMI for states model. We also examine sustainability outcomes to compare the changes in these types of outcomes under the two approaches too. One limitation of this approach is that we are not providing information for all aspects of integrated health programming. We are not providing information for stakeholders with particular interest in delivery care or nutrition, for example. This is an example of a trade-off as we balance the breadth of integrated programming and the practical constraints of time and budget. Other evaluations of integrated programs might make different trade-offs depending on the specific questions and priorities in that evaluation. So here we show the overarching evaluation questions we are aiming to address. There are three broad domains for the questions. First, we have effectiveness. We have questions related to effectiveness on health and service delivery outcomes and on sustainability outcomes. The third question aims to explore which implementation strategies are associated with improvements in outcomes, but that will be a qualitative analysis. There are too many different strategies to explore them all quantitatively. We also have questions related to process, specifically to coordination and collaboration, and to facilitators and barriers to implementation in different contexts. Finally, we have a broad economic evaluation question, but given the difficulties of collecting comparable detailed cost data across multiple states and activities, we are limiting the economic evaluation to exploratory analysis of costs in each state to contextualize the other information collected. So the evaluation uses mixed methods to collect data on different components of the evaluation. On the quantitative side, we are collecting health facility assessment and provider interviews at baseline and endline. These are to explore health facility readiness and provider knowledge, attitudes, and practices, which were gaps in existing data. We are using the DHIS2 or District Health Information System data to look at that annually, to look at health service use. We are conducting organizational and network analysis at midline and endline to explore coordination and collaboration. We have the costing component, a very basic costing component that I just mentioned. And we're also exploring secondary analysis of survey data, such as the demographic health survey, the multiple indicator cluster survey, the malaria indicator survey, and the behavioral surveillance survey being conducted in some states by breakthrough research. And I'll now hand to Jessica to talk about the qualitative data.
Thank you, Sean. Qualitative data will contribute to answering evaluation questions, help to monitor implementation of the activities, provide contextual information, and explore the validity of critical implementation assumptions that we made during the development of the theory of change. We include annual process monitoring consisting of structured key informant in-depth interviews with key stakeholders, such as implementing partner staff at national and state levels, USAID staff, and state government staff. The topics for the process monitoring rotate each round. So far, our first round, conducted last year, focused on coordination and collaboration and state work planning. And our second round, conducted recently this year, focused on sustainability. At midline and endline, we are also carrying out focus group discussions with women and men in communities and with board and facility development committee members, as well as key informant interviews with health facility in charges. This data collection will get us down to the community level to understand experience with the activities, quality of care, and factors affecting demand. Lastly, we are using the most significant change method in a workshop format with stakeholders. The stakeholders will be asked to share stories of change and then do engaging group discussions about the stories and recollections of significant change in order to articulate perceived activity outcomes. They will discuss the value of these reported changes and which they think is the most significant of all.
So the evaluation design was completed in 2020. In 2021, we completed the first round of process monitoring, focused on coordination and collaboration, as Jessica just mentioned, and shared those findings with stakeholders at the federal and state levels. We also completed data collection for the health facility assessment and the provider survey and shared preliminary results from the provider survey with USAID Nigeria. So far this year, we have completed the second round of process monitoring focused on sustainability, the organizational network data collection and initial analysis, and completed preliminary analysis of DHIS2 data. These results, along with the findings from the health facility assessment and the provider survey, are currently being shared with different stakeholders. Note that analysis is ongoing and we will be building results up over time. This is related to the core design principle of providing results on an ongoing basis. But it means that at any given point, what we share refers to what we know at that point. And that will evolve over time as more information and more analysis is added to the evaluation. Okay, and I'll now hand over to Jessica to talk about the qualitative findings.
Thank you. We are currently conducting the midline qualitative data collection, so do not yet have results to share from that component. So today I'm sharing results from the process monitoring related to the integrated versus malaria-focused approach. In April 2021, we conducted 46 key informant interviews with state program and government stakeholders, along with USAID stakeholders. That round, as I mentioned earlier, focused on coordination and collaboration of the activities and on state work planning processes. Several themes emerged related to perceived challenges of the integrated versus malaria-focused approaches. So first, the selection process for sites was different for IHP, the integrated program, versus the malaria project, PMI for states. and also the PSM project, which handles the commodities. So some IHP facilities might not be prioritized by PSM. You can see under PSM's malaria task order, commodities were provided to high malaria volume facilities. However, IHP operates in one public health center per ward, which is not necessarily a high volume malaria facility. And the state had a say in those facilities selected by IHP, and they just may or may not be one that see their location. So in the integrated programming, they may not be working with the higher volume facilities, and this could mean that they would have lesser effect on malaria outcomes. Next, the integrated program could run into political issues related to the kinds of services it offers along with malaria services. An activity coming in with just a malaria program may have wider acceptance than one coming in with malaria and family planning services, when family planning services are less socially or politically acceptable. You can see here a quote on the right that we got from one of the mission respondents saying that family planning doesn't get the same acceptance that a mosquito net does. Stakeholders also noted, specifically for malaria-focused programming, that the cost overall of developing commodities is higher under disease-focused approaches because only specific commodities are distributed and others have to be managed by other means. Our process monitoring respondents also suggested some issues in KEBI related to coordination with government agencies, and this may be related to the implementation approach. You may recall KEBI is one of the integrated states. It's possible that integrated programs may face greater challenges than disease-focused ones in working with fragmented government agencies, since it is difficult to coordinate with many partners together versus each separately. In KEBI, IHP is meeting to address concerns from different agencies to ensure there's clear understanding of IHP's roles and responsibilities. We did not see this in the other integrated state of Ebonyi, however, and this is something that we will continue to explore. Overall, the first round of process monitoring found many of the emerging themes were similar across the 3 states, despite their different programming approaches and the presence of a different combination of activities in each state. Even with the large number and complexity of relationships, coordination among the activities and with the states was working quite well, although there were some competing priorities and lack of time noted as common challenges. And now I will pass back to Sean to talk about the organizational network analysis.
Great, thanks, Jessica. Next slide. The organizational network analysis provides quantitative data on coordination and collaboration to complement the qualitative process monitoring data that Jessica just discussed. The ONA data was collected in February and March this year. I won't go into details of the methodology and the results here, but will present some selected results to illustrate how networks vary across states. The organizational network survey asked about 3 types of sharing: resources, information, and funding. Overall, networks for resource sharing and information are extensive and complex in both integrated and malaria-focused approaches, although they differ across states. So this slide shows the resource sharing network of Ebonyi. Don't worry about the details of this image. Focus on the overall shape and the impression, and keep that in mind as we look at the other 2 states on the next 2 slides. Overall, this network is moderately dense and relatively efficient. Density refers to how many connections there are in the network, and efficiency is a measure of how many steps it takes to share resources between one organization and another in the network. This is the resource sharing network for KEBI. You can see immediately that this one looks different. It is less dense overall and less efficient. This could possibly be related to the fragmentation noted in the qualitative data collection, collected in the process monitoring that Jessica just discussed. Right. So Zamfara is the malaria-focused state, and you can see that this network is different again. It is the most dense network, at least for resource sharing, and has moderate efficiency compared to the other two states. So organizational network analysis is useful as a tool to stimulate discussion. There is no right or wrong network, but it does allow us to see how networks differ in different contexts and explore potential connections that would enhance the network in various ways. We are exploring additional analysis of these data to provide further insight into coordination and collaboration in integrated versus malaria-focused programming approaches. So now I'm going to talk a little about the results related to sustainability. So I'll start by briefly describing how we approach measuring sustainability. This diagram provides a conceptual framework that we use to guide the measurement process. We define 4 main functional areas that are expected to influence transition, routinization, and institutionalization of activities to ultimately lead to sustainability of the activity. At this stage in the process monitoring, we are focusing on those intermediate elements that support longer-term sustainability and are expected to reflect how activities implement their work. That's primarily the gray boxes in the second column. Next slide. So there are 2 components to the sustainability data collection. The first part was a questionnaire adapted from the Program Sustainability Assessment Tool developed by Washington University in St. Louis. This questionnaire included statements across 12 domains and 3 functional areas that participants responded to using a Likert scale, where 1 reflects to an extremely small extent and 7 represents to an extremely large extent. The questionnaire was administered to 161 purposefully selected respondents. We also conducted key informant interviews with 24 respondents to get more detailed information on these functional areas. So I'm going to present just a couple of examples to illustrate the type of results obtained by state. So this spider chart or radar diagram shows the mean Likert scale scores for each item in the program adaptability and alignment domain. This is an example where there is relatively little difference between the 3 states at this point in the process. Ebony tends to score higher than the other 2, but the differences are small and scores are relatively high for all states. So this is an example of a domain that shows more variation by state. The differences at this point are not systematically different by program approach, but Zamfara, the disease-focused approach, tends to score slightly better than the 2 integrated states on several items. Ebony scores weakest of the 3 states. So what the evidence on effectiveness on sustainability outcomes is limited at this point because we're still in the early stages. We've only done 1 round of data collection focused on perceptions of intermediate processes to support sustainability. But what can we say now? Differences between states are small at this point. Both integrated and malaria-focused approaches incorporate multiple elements expected to contribute to sustainability. Our initial impression is that state context, things like political economy and interpersonal dynamics, likely has a bigger influence on progress towards sustainability than integrated versus disease-focused approaches. Structural constraints, such as funding and human resources and time, limit progress towards sustainability in both program models. And at this point, we're thinking about developing objective measures of progress, particularly focusing on the transition, routinization, and institutionalization components of the framework. Okay, so now I'm going to talk about the final set of results related to health service outcomes. So one of the questions related to integration that came up when we were designing the evaluation was whether PMI will still be able to show strong malaria results under an integrated model. So our evidence so far indicates probably yes. Malaria indicators examined across the theory of change are relatively strong in all 3 states, including Kebbi, where IHP is operating an integrated approach alone. But we do need to look at this further to see whether this translates into health outcomes at the population level once we get the survey data to look at next year. And we also need to explore issues of scale, because the IHP model is only operating in one primary health facility per ward, whereas the PMI for states model is able to operate in more than one facility per ward, which could have impacts on outcomes. Here we illustrate how we use the theory of change to synthesize results for one of the comparison services, in this case, family planning. So provider attitudes and norms related to family planning are a potential barrier to family planning service provision, and so more attention is needed to this. The responses from the clinical vignettes in the provider survey show gaps in family planning counseling, and some gaps in the availability of multiple methods at facilities was observed in the health facility assessment data. We also found through the breakthrough research survey that some declines in positive attitudes to family planning were found in KEBI despite increased use. Of note from the integration perspective is that family planning indicators were generally weaker in Zamfara at all points in the theory of change, but that is out of scope of the malaria-focused activities in the state. Okay. And now I'm going to hand back to Jessica to talk about gender integration.
Thank you, Sean. So I am going to describe gender integration in the evaluation and also share some gender-related results that we have so far. Gender is being explicitly integrated throughout the evaluation, and we will explore whether the integrated and/or disease-focused approaches contributed to gender equity from both supply and demand perspectives. And I have here on this slide just some examples of how we have addressed or are addressing gender throughout the evaluation. This is by no means comprehensive. So one example related to the theory of change, we describe how the programs address gender. Then in our key informant interviews and the process monitoring, we sampled both men and women and asked about use of gender data in planning. In the provider interviews, there were questions on gender-related attitudes and norms. In our data collection processes themselves, we've done things like sex match, focus group discussion facilitators to participants in data. And in our quantitative data analysis, we're disaggregating by variables such as sex and age to the extent possible, and deliverables will include discussion of gender-related results. So far, we have gender-related results from the provider survey and the sustainability component, which you've heard a little bit about already from Sean. From the provider survey, we found that training on gender issues, including gender-based violence and male involvement in family planning, were low, except in KEBI state, where training was moderate. Gender norms among providers were most gender equitable in Ebonyi and least in Zamfara. And gender-based violence screening and engagement, as measured through clinical vignettes, were low across all states, but Ebonyi again scored highest. From the sustainability survey, we saw that Ebonyi showed the highest scores for gender, typically followed by KEBI, and then lastly, Zamfara. I'm sharing this just as an example to show how the three states have tended to fall in terms of gender equity. So this is describing an example where we calculated a provider gender attitude score based on 13 statements related to reproductive, maternal, and neonatal health service provision and quality of care. You can see here on the upper left one example of those 13 statements. So a woman should not use a family planning method unless her partner agrees. The calculated score ranged from 1 to 4, with a higher score or disagreement indicating a more gender equitable attitude. Then the graph on the right presents the score distributions across the three states. So Ebonyi had the highest score, indicating the most gender equitable provider attitudes, whereas you can see Zamfara in orange and KEBI in dark blue. We're tracking closely together with Zamfara being the least, or showing the least gender equitable attitude. And now I will pass that to Sean.
Okay, thanks, Jessica. So finally, we'll turn to some lessons learned on implementing this evaluation of an integrated health program. Okay, next slide. So many of the technical and measurement issues we are facing in this integrated evaluation are similar to those we encounter in other types of evaluation. For example, we are working through issues with the quality of DHIS2 data, and our results so far should be viewed as preliminary while we explore these data quality issues further. Measuring quality of care was another issue we had to decide how to handle. There are multiple approaches to doing that, each with strengths and weaknesses. We decided to use clinical vignettes and have learned a lot about implementing those, but that's a topic for another webinar. Because of the integrated nature of the evaluation questions, we had to include multiple clinical vignettes to cover different health services that we are including in the evaluation, even though we limited the number of services that we were covering. And some of these work better than others. And as in all evaluations, change takes time, which limits what we can say at this point in the evaluation about questions of effectiveness and so forth. We have to balance the need for rapid information, which is part of our core principle, with the risk of drawing premature conclusions. Another learning theme is around the challenge of balancing breadth versus depth when evaluating integrated programming. The complexity of the portfolio and the mechanisms of action mean that the questions and related evidence are often broad rather than specific. We need to balance providing evidence that is specific enough to be useful, but not so detailed that people get lost in the weeds and lose the big picture. Getting the level of information right is a challenge, and I think we're still working on that. There are a large number of potential questions and analyses. Different stakeholders have different topical interests that they want more specific data on. The evaluation needs to be responsive to evolving needs, but also needs to prioritize to stay within available resources and be sure to address the larger question. The theory of change helps with putting the pieces together, but it is high level, which brings us back to the level issue, being specific enough to be useful, but broad enough to address the connections between different pieces and maintain the big picture. Finally, the case study approach is practical in containing the scope of the evaluation, but limits its generalizability in that it is hard to separate out the approach and the context. An alternative approach might have been to include more states, but then the focus of the evaluation would need to be narrower to achieve manageable boundaries around the evaluation scope. Another related lesson concerns handling the volume of information generated in this integrated health program evaluation. I touched on this earlier when talking about the clinical vignette. The integrated nature of the program means that there are more types of stakeholders to involve in qualitative data collection and in the result review process, and more outcomes to collect data on. This means that instruments are longer, which requires more time of respondents and more time for analysis. More synthesis is required to put all the pieces together. It also generates a lot of information to share, which can be overwhelming. Everyone is very busy, so it can be hard to schedule extended time to deeply engage with the complex results. Many of these challenges are not unique to evaluation of integrated programs, but they are magnified by the volume of information when examining multiple outcome domains. In response to these challenges, we are rethinking ways to break up the evaluation into bite-sized pieces in a more ongoing results review and use process. That will also allow analysis to be conducted on a more rolling basis and adapted to emerging needs of different stakeholders. But it will also be important to keep the larger goals of the evaluation in mind and include ways to put the pieces together periodically. And I think at this point, we are ready to open up for discussion. Thank you, everyone.
Thank you, Sean. If you have any questions or comments, please enter them in the Q&A or feel free to open your microphone and ask directly. We will we'll take 10 seconds to see what's coming in.
Okay, so I'm going to sort of try and address the first question, which my eyesight is struggling with. So with regard to the health outcomes, do you have any integrated health outcomes, for instance, such as receipt or utilization of several services at a time? At the moment, no. This is partly due to the limitations of the data sources. We are not doing at the moment population-based data collection or any population-based surveys because of some of that cost considerations, and there was also already some population-based surveys going on. So we're limited to what is asked about in those surveys. And the DHIS2 data also is our health service use outcomes, and that also is by survey. So except to the extent that any of the surveys, like the behavioral surveillance survey that Breakthrough Research is doing, if they sort of add that in, we might be able to do that. They've been a little bit limited because they were supposed to be working KEBI and Zamfara, but and did baseline in both states, but the midline they weren't able to do in KEBI due to the local security situation. Is there anything in the most significant change that might get at this?
No, not as of yet. That's going to be at a higher level talking with stakeholders. It's possible that under the qualitative, when we're at the community level talking with men and women who receive services, that something would come out.
Okay. All right. I see Bill Weiss is asking, please go into more details, Ray, move to a more tailored dynamic results review and data use approach. This is something we're still thinking about. It's a kind of really a lesson learned from the last 3 weeks as we've been going through this process. And I think if there's anyone from USAID Nigeria on, they might want to comment on that. And I think one of the things that's challenging when there's so much information is different people have different needs and different particular decisions they're trying to make. And when we presented like a general presentation, we can't really tailor to those specific needs. So we're trying to encourage sort of an ongoing conversation with different stakeholders so that they can reach out to us and say, hey, I've got this decision, or this we're thinking about this. Can we talk through how this data might be relevant to that, or we've got this specific question, and we can sort of do something a little bit more tailored around the specific needs and questions. And that could be briefs or analyses, but it could also just be conversations and sitting down and talking through things with people to understand what their needs are and how our data might apply to that. So that's the kind of thing that that I'm sort of thinking about. We do have Emmanuel Adekwi, who I think is on this webinar today, who's our in-country lead, and other team members there that are in a position to be sort of responsive and really try and facilitate use that's very tailored to what people actually need. Okay, and then Gulshad here saying, thank you for the interesting presentation. I understand that the project time span is 20 to 25, and the evaluation activity started as early as the end of 2021. Do the benefits of generating early findings on an ongoing basis outweigh the drawbacks of burden to program implementers and the financial resources required for extensive data generation? That's a big question. I think we are very conscious. I mean, originally, as we were thinking about this, we were thinking about that ongoing collaboration as a core principle, which was sort of widely agreed to. But that does come with time costs. There are very big time costs to that. I think you're right. And we have scaled back a little bit, especially as after we designed this, the pandemic came along. So we have sort of scaled back some of our data collection because of that, and also some of the engagement on collaboration and engaging in results. So I think this is definitely a balance. Whether the benefits and costs outweigh each other probably depends. It varies according to different people and what their perspectives and priorities are. So I think that's, but it's definitely an important consideration. I don't know if Jessica, do you want to comment on that too?
No, I think the most burden that we have with working with implementers and other stakeholders has been through our qualitative, the process monitoring, and also the ONA and sustainability piece. And one thing that we consciously did in the most recent round of data collection is tried to coordinate those in such a way as to minimize burden. And also we reevaluated our list of informants to try to scale those back as much as possible, while still getting being able to answer questions that we've had. So I don't know that it's I can't say whether there's benefits, the benefits outweigh the drawbacks, but just know that we're paying a lot of attention to that and trying to minimize burden as much as possible.
Dakalo is asking how many qualitative questions did you have?
So if you're asking about how many qualitative research questions we had, the 5 research questions that we had that were not related, so there were 6 research questions. One of them is related to cost, and that does not have a qualitative component as of yet, but the other 5 questions are to some extent being answered through the qualitative component.
Okay, so did you measure the effect of male engagement in family planning uptake? We do have, let me say exactly, we do have some questions in the clinical provider, in the vignettes, in the provider survey. The family planning vignette does include elements of male engagement. So we do have some indicators around male engagement coming out of, in terms of provider knowledge, attitude, practices around that. And we also have, as Jessica mentioned, a lot of gender attitudes and norms, some of which relate to male engagement. Do you want to talk a little more about that?
We also looked at training on male engagement. And in the qualitative component that we are integrating now, there are questions for the community members on their experience with services, and that may get into male engagement to some extent.
Okay, and then Rick is asking, Susan is asking, are these all public sector facilities? Yes, we are limiting it to public sector facilities. In New Bonny, IHP is working in some private sector facilities, but for comparability, because it's predominantly private in the Northwest, we decided to limit to public sector facilities. So, yeah, and primary healthcare facilities too. Okay, Rick is asking, related to Denise's, I just lost, there we go. Related to Denise's account about individuals that receive services across multiple areas. Do you have access to any sort of electronic medical record data that could track this? We haven't come across that, but that is something we could look into a little bit further. I don't know if, Emmanuel, if you know anything about the EMRs, you could type that into the chat, but at the moment, we have not planned to use those data, so I guess we could look and see if there's anything that might be useful on that front. Thanks for that suggestion. Sarah is asking, are there any processes you have introduced as a team to keep on top of the large volume of data collected to enable effective review, discussion, and synthesis between partners? Thinking about that one. Anything? I mean, we're working as a team constantly to really try and draw things across, but I'm not sure that there are any very specific processes other than that we meet very frequently and that we review the data together a lot. But it is a large team. So I'm not thinking of anything specific that I could describe. I mean, certainly, Sarah, if you have thoughts and experiences with that, we would love to hear them. Because it definitely is an issue, the volume of data is an issue. We have been sort of, trying to sort of prioritize, and we sort of think, well, we'll do a first round of analysis and then we'll build on it later. So we don't try and get everything done on everything all the time, because that would never get done. So we are sort of working in a kind of staged approach in that let's get some preliminary results out, and then we'll go into the next level of analysis, and then the next level of analysis, and so that we can keep bringing them together. We also very consciously try to integrate the sustainability quantitative data from the LICET scale with the qualitative data from the interviews, and similarly for the coordination and collaboration, look at the qualitative process monitoring results with the LNA data. There certainly continues to be more that we could do, however. Okay, I know, so Ekaterina is considered the lessons learned. What would your approach to design a rapid situation assessment of multi-sector intervention in several countries? I'm wondering, are you having to do that if that's a challenge? I mean, when it's a rapid assessment in multi-sector intervention in several countries, that's a challenge with 2 months duration. That's a very small, very short time frame. I think you would have to be really limited to sort of a rapid document review and key informant interviews, but you're not going to really get much depth in that amount of time. I don't know if you have anything to add to that, Jessica.
I think managing expectations of the funder is often a challenge when doing rapid assessments with multi-sector interventions like that.
Yeah, that's a challenge. And I think that is something that I think is a larger conversation about when we look at these very complex interventions. And there's a couple of articles, I think they're in, I'm trying to remember what they are in Global Health Science and Practice or some other, there are a couple of articles I've read on these larger like portfolio evaluations of things like Gavi and things like that. And there's some kind of interesting lessons learned around that also echoed with experience I've had doing portfolio level evaluations for a different funding agency. But then again, they were also talking about more than 2 months, I think. Mm-hmm. Okay, Fidelis has asked, there is a interesting findings around sustainability on the state context. How could we unpack more political economy, interpersonal dynamics to understand drivers to sustainability much better? When I'm thinking about it, I think some of that comes to some of the qualitative, triangulating the qualitative and quantitative data. I think and also bringing in some of more objective measures as well. I think one limitation of what we've got at the moment is it is self-reported perceptions. And, when we've discussed those with stakeholders on the ground, there's discussions about whether people can mean different things by this and have different expectations. So I think it comes down to sort of looking at this as a clue to where we might want to dig deeper. And that's this sort of iterative process of qualitative interviews to dig deeper on certain pieces, and then looking for some more objective quantitative methods like funding releases and human resource gaps and some of those kinds of things to try and put together a more holistic picture. I mean, even just in the key informant interviews, you can hear different things coming out in different states, not so much related to the integrated versus vertical programming, but more, or disease-focused programming, more related to expectations, which are also influenced by past experiences and how many funding agencies are working in the state, and some of those kinds of factors can play in as well. You want to add anything to that?
Right, the data collection that we're doing right now for midline, the most significant change work, we'll be able to get into this a little, again, it'll be data triangulation. We have a domain we're looking at specifically on sustainability. And so I think this idea of just building the evidence over time, we don't have a lot to unpack right now, but in another year, we'll have more layers of this. Okay, so then fine on time. So Bill is asking, there is a lot of talk about adaptive management in programs, but less information about how to implement it. This evaluation design can support adaptive management. Any examples of changes to policy or implementation to date in the program areas? I don't think so, particularly any specific examples that I'm aware of. We have shared results on process monitoring and provider surveys with USAID Nigeria, and we only recently, just even yesterday, shared the latest round of findings. So we're trying to shift the timing slightly so that we present things in line with work planning cycles. I think one of the things we have to be a little bit careful around is that balance between, well, a few things that around this is, one, adaptive management doesn't necessarily mean changing things. If things look like they're going well, the actual action is not to change it. So I think it's a little bit one-sided thinking it's got to be a change, because sometimes that's not the appropriate response. We don't have to change things all the time. A second piece is that as you build up more, there's a bit of a timing issue. Some of the most useful information comes later in the evaluation, which is just a mismatch. And I think Jennifer Bryce has talked about this in terms of the timelines for evaluations and the timelines for decision making. And I think also Quinn Patton then has also talked about some of these challenges of different types of things. Different types of information comes in on different timelines.
So right now we have information that's more on the process side of things. I think it'll be interesting to see what comes out of the midline if we get a little bit more information out of that on change. So you're constantly evolving, and as you get further into the evaluation, you're going to see more obvious things which may lend themselves to more tweaks. You also have a level issue here because it's a big picture question, and a lot of the day-to-day decisions are on a much more micro level. What I think has been helpful is that when you are able to get people together, which has been hard to do the last 2 years because of the pandemic, the data often starts a conversation. So it's not necessarily the specific result that leads to action. It's the conversation around that result that then leads to people talking about issues and, talking about, for example, some of the conversations around, oh, that's around coordination and collaboration. One of the partners saying, oh yeah, we really need to strengthen our coordination and collaboration here because we can see from these results that we need to do more on that. And having a joint discussion around supply chain issues. So I think it's that kind of conversation that has been most interesting. So it's a more subtle than just saying this result leads to this finding or this policy change. And if you want to add anything, Jessica? Okay. James also added what measures of influence could be developed to measure political economy and interpersonal relations. So we have to think about that. Yeah, I think some of that stuff is also quite sensitive and more qualitative. It would be a little bit hard to measure quantitatively. I think I'd certainly be open to suggestions if anyone on the webinar has thoughts on or has experience with measuring those kind of dimensions. I'd definitely be interested to hear about that.
If that's something that we've explored.
Yeah. Okay. Did the evidence present some consistency with interventions in different climes you can share? I'm not quite sure. I'm not quite sure different.
In terms of that, maybe they're getting at. So we had IHP in 2 different states that with different climates, right? Different political climates, different social climates. So I mean, from the process monitoring, I'd say the answer is yes so far. We've seen similar things come out with the same program approach in different contexts. But that's, that was just from one round of process monitoring. So this, we assume, would evolve over time as the project evolves.
So was data sharing across countries an issue? Well, we're only working in Nigeria, but across states. Right now, we are doing state level disseminations, and so far we're presenting at the state level. We've been focusing on the state level results and not so much on the comparative perspective. And we've tried to be sort of sensitive to whether there might be any issues sharing across states. But actually, I think for many of the results now, we're going to actually put out one brief that does compare all of them, because there's actually some interest in seeing how different states perform, and it's part of the and most of the information we're sharing isn't particularly sensitive.
So I think it's right now 9:59. We have a number of questions left. We're going to choose a few of these and try to get through as many as possible. This one is
So Gulshad asked, could such an in-depth ongoing evaluation process early in the program lifetime substitute to some extent internal program monitoring processes? I don't think so, because I think they have different purposes. I think what we're trying to do is at a higher level, and it's sort of bigger picture questions, more strategic questions, and we can draw on some of the program monitoring data, but it comes back to that level issue I raised. And I think for a lot of the ongoing program decision making and program management, they need sort of more in the weeds, more sort of day-to-day operational data. And that would be too much for evaluation like this when you're trying to do it over multiple activities, multiple states and so forth. And we don't have that sort of closeness to the activities to be able to interpret that in context. So I think it is a different, I think they have different goals, and the levels of data required are a little bit different. And,
can do one more here, and then we'll have to wrap up.
How practically did you engage stakeholders to go the way of integration of health services? Was there resistance? If yes, how did you anticipate or face them? So Nicole, so we were not really promoting either integration or non-integration in the evaluation. We're trying to step back and look at the pros and cons and just try and describe really what are these sort of processes of working in an integrated and a disease-focused approach, and what are some of the happens to the different outcomes in those different contexts. So we aren't really trying to promote one or the other. We're just looking at what the evidence is around that. I mean, I think in terms of how we engage stakeholders, we've been reaching out regularly, both to the implementing partners and to USAID. We've been trying to share things with them. Now, again, there's that balance, because we're also trying to be mindful of their time, and everybody's been really busy, and it's been an extremely unusual period. But we have had great collaboration with all of the implementing partners, and I would really like to thank all of them for their cooperation and how much time they have given us in providing data and supporting the evaluation and engaging constructively and energetically in discussions around the results. So there has been, we recognize there are constraints, but we've had a good cooperation, and we've tried to meet our objective of having a participatory evaluation while also respecting people's time.
I think we're going to have to wrap up there. Thank you so much, everyone, for the thoughtful questions, and we hope we've been able to at least touch on some of the thoughts that are helpful for you. We will be sending out a link to the recording of the webinar along with the slides to whatever email address you registered for. And you'll also be able to get a copy of all those materials on the Data for Impact website. So thank you very much. Good morning, good afternoon, wherever you are, and we will hopefully see you again soon on a future webinar.